anesthetics are used in dentistry to control pain. They're very effective when they can stay in one area, but the body begins to disperse it through blood vessels immediately, and therefore many of them don't last long enough for certain dental procedures. So vasodilators are added to keep the drug in the area longer, but it doesn't come without its costs. We'll discuss their mechanisms of action, touch a little bit on biotransformation, and take a look at the toxic effects that the use of LA can present. It all started with cocaine around 1860. Cocaine is an extract from the cocoa leaf, and people noticed that it would make their tongues numb. They began experimenting with it, trying to uncover any therapeutic purposes, but what they found was that it was very toxic and highly addictive. It did become a good local anesthetic for eye surgery, though, in 1884, and then introduced in dentistry the same year. In 1901, a Japanese researcher isolated epinephrine. Soon after that, it was realized that if it was added to cocaine solutions, it didn't absorb into the body as quickly. This allowed lower doses of cocaine to be used, but still, it had its many downsides, so the search for better drugs continued for non-addictive alternatives. Procaine was first developed in 1904 in Germany and marketed in the U.S. as Novocaine in 1905. It was a tremendous success as a local anesthetic in replacing cocaine solutions and was relatively safe. Its effectiveness, though, was unpredictable, and some people had allergic reactions. It's withstood the test of time, and even though it's been replaced with less problematic drugs, it's still recognized as the prototype of modern local anesthetics. There are two goals for a local anesthetic in dentistry. One is to produce anesthesia in specific areas long enough to get procedures completed, and two, to reduce localized bleeding. It also allows many procedures to be done without having to be put under general anesthesia, which holds significantly more risks. There are two primary routes for local anesthetic drugs in dentistry: topical and submucosal injections. Topical works well intraorally because the oral mucosa is so thin that the drug passes through with ease to the underlying nerves. Of course, submucosal injections are more profound and effective because they're placed near and farther up the branches of nerves. The desirable effects of local anesthetics are that they need to have a high level of biocompatibility with no systemic effects. It should have a rapid onset, no toxicity to tissues, have a therapeutic duration long enough to allow standard procedures to be completed, and be potent enough that a reasonable amount will do the trick. It also needs to be sterilizable, readily biotransformed in the body, as well as provide adequate topical effects at low concentrations. All 5 local anesthetics today on the market have reasonably low toxicity levels, quick onset of actions, reasonable durations of effectiveness, take a reasonable amount of time to be metabolized, and are relatively non-allergenic. Injectable local anesthetic drugs are classified as either amides or esters. Each have very different chemical components. The difference between them is based on the makeup of their intermediate chains within the molecule. Amide chains contain a nitrogen atom, whereas the ester chains do not. The intermediate chain helps to separate the two different ends, one being hydrophilic and the other being lipophilic. The lipophilic property allows the drug to pass through the biologic membranes of nerves, and the hydrophilic properties allow the agent to disperse in extra and intracellular fluids. This also helps with biotransformation. But how would you know the difference if you saw it on boards, which you will? So, according to box 4.3 in your text on page 37, you'll notice that the word amide and all the names for those drugs contain a letter I in the first and the second syllable. The esters have no I in the beginning syllable. So be sure that you know that and look for that. Pharmacokinetics is what the body does to a drug. This includes absorption, distribution, metabolism or biotransformation, and elimination. Dental anesthetics are prepared as acid salts by adding hydrochloride. You can see it on the label. This helps the drug dissociate into two forms when in body fluid: a positively charged molecule called a cation and a neutral molecule called the neutral base. Local anesthetics are dependent on the actions of both of those molecules. How they react once in the nerve membrane determines the drug's potency, duration, and overall efficacy. Pharmacodynamics is what a drug does to the body. This includes what they do to peripheral nerves, the central nervous system, and the cardiovascular system. It's best described by the specific protein receptor theory. It states that the cation portion of the local anesthetic molecule binds to the specific protein receptor site on nerve membranes. This temporarily inactivates the ability of the nerve membrane to become excited. 90% of local anesthetic actions are due to the binding of this protein site. If you remember from the previous lesson, the calcium molecule binds to the ion channel and it keeps it closed. Local anesthetic will displace that calcium molecule and bind to it, keeping the ion channel closed longer. The membrane expansion theory also states that the neutral base portion of the local anesthetic molecule modifies the nerve membrane, narrowing the diameter of the ion channels, limiting sodium ions from entering. Vasoactivity is a very important consideration when using local anesthetic. All local dental anesthetics are vasodilators. This promotes the drug to be readily absorbed into the bloodstream, rendering the clinical effects to be shorter and increasing the possibility of systemic toxicity or adverse reactions. It also requires more anesthetic to maintain anesthesia, so vasoconstrictors such as epinephrine are added. Some amides, such as prilocaine and mepivacaine, can be used without a vasoconstrictor because they're weak vasodilators. It just depends on the treatment to be done. Lidocaine is a potent vasodilator, so it isn't very useful without a vasoconstrictor. Vasoconstrictors help retain the drug locally to the area of deposition for longer periods of time, and it reduces the risk of rapid uptake, which can lead to an overdose. Once a local anesthetic begins to be metabolized, it enters the circulatory system. These unbound molecules are delivered all throughout the body, affecting highly sensitive organs, among which are the central nervous system and the cardiovascular system. All dental local anesthetics, with the exception of bupivacaine, affect the central nervous system well before they impact the cardiovascular system. Toxic overdoses are usually the result of excessive doses, intravascular administration, rapid delivery, and or slower than normal biotransformation or elimination. A patient's age, their weight, their health status, and the routes of administration can all be factors. When used within proper limits, local anesthetic drugs don't exert any significant effects on the central nervous system, but at high doses, a local anesthetic overdose can manifest as central nervous system depression. This occurs in two phases, what's called biphasic. It first starts with central nervous system excitation, and then it goes into a central nervous system depression that can lead to tonic-clonic convulsions, coma, and respiratory arrest. The central nervous system excitation phase can look very similar to a psychogenic reaction of fear and anxiety that have nothing to do with local anesthetic dosage at all. So it's important to keep track of how much anesthetic is given and keep an eye out for central nervous depression if you're not sure. Similar to central nervous effects, cardiovascular system effects don't usually manifest with recommended amounts of anesthetic. A true overdose of local anesthetic will have the typical biphasic events in the central nervous system. First, heart rate and blood pressure may increase. If dosing continues, then there can be a sudden drop in blood pressure. Heart contractibility may significantly decrease, which could lead to cardiac or respiratory arrest. Box 4-5 lists the signs and symptoms of central nervous system overdose toxicity. It'd be very important for you to study this box. This is how things usually occur for all local anesthetics except bupivacaine. Bupivacaine is the most toxic of all local anesthetics, up to 16 times more cardiotoxic than lidocaine. It's the one that lasts the longest. It's the most likely to induce an overdose, and when an overdose does occur, it's more difficult to reverse than any other anesthetic. Once absorbed into the body systemically, the drugs are distributed to organs that are highly vascular, such as lungs, brain, heart, and kidneys. They receive more of the drug than other organs. It only makes sense also that if a drug's delivered in an area that's highly vascular, that it will be absorbed more quickly. The metabolism of local anesthetic drugs reduces their toxicity. The drugs are broken down into their components called metabolites. This is done in two places. All amides, with the exception of articaine, so that's bupivacaine, lidocaine, and mepivacaine, are primarily biotransformed in the liver by the hepatic P450 isoenzyme system. Esters, on the other hand, such as procaine, benzocaine, which is topical, and tetracaine, which is also another topical, as well as articaine, are biotransformed in the blood by an enzyme called cholinesterase. They're then excreted from the body through the kidneys. The elimination half-life is the rate at which a drug is removed from the systemic circulation by the kidneys, also thought of as the time necessary to metabolize and excrete 50% of the drug. Lidocaine, for example, has a half-life of 1.6 hours. When calculating it all the way through, it will take 6 half-lives, or more than 9 hours, to completely remove the drug from the system. Each anesthetic drug has its own half-life. Dentists will use this more. Understanding these will impact drug selection and treatment planning, especially if it's necessary to administer additional doses after the maximum recommended dose has been given.